Got it.
This meeting is being recorded.
All right, so welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Medical and Professional Affairs Committee. Today's meeting is officially called to order. I'd like to propose a motion to adopt the minutes for the MNPA committee meeting that was held on April 11th, 2022. Could I have that seconded?
Second.
All right, let me go through each member then. Dr. Martone,
Yes.
Barbara Lowe, Barbara, I'm not hearing you yet, so I'm not sure if you're on mute. Hopefully we'll connect. And Sally Hernandez Pinheiro
Yes.
and Jose Pagan.
Here, yes.
And I didn't notice, is Dr. Katz there?
No, Dr. Katz is not with us as of yet.
All righty. Okay, motion carries. So next we have 3 action items for consideration. We'll be hearing from Dr. Ted Long. After each presentation, I will call on each member individually for comments and questions. So you can wait till the end of the presentation, but if there's anything that seems really urgent, you can certainly interrupt. I'm sure Dr. Long won't mind. I did want to note that in the first resolution on slide 6 and 7, there is mention of DocGo, which should be consistent with the name RRT that was indicated in the resolution. So that will be a change, which will make certain takes place prior to the presentation to the full board. There's also a mention of CTS on the bottom of the slide, and that should be Centera, CENTERA Health, Inc., as also indicated in the resolution. So let's make sure we have those updates before the resolutions are presented to the entire board. And if we can, Dr. Long, if we can begin the presentation.
Hi, good morning. Can you hear me okay?
Your mic is now.
There we go. How about now? Can you hear me okay?
Better.
Wonderful.
Better, thank you.
Good morning.
I'm going to read this first.
Okay, wonderful. Good morning. This is Chris Keeley. Dr. Ted Long wasn't able to make it, unfortunately, this morning. He asked me to step in for the first 2 resolutions here. So this resolution is authorizing New York City Health and Hospitals Corporation to enter into standby contracts with the following 6 firms: Rapid Reliable Testing, Inc., aka DocGo, MedRite Urgent Care, Centena Health, Inc., Elevation Health, LLC, Premier Assist, and Fulgent Genetics, Inc., the vendors, to perform COVID testing when necessary, as directed by the system's president, with each contract to have 2-year term, and with the set of contracts not having a pre-established not to exceed amount. So the 2 proposals that I was hoping to put forward today here for your consideration are very related to each other. One is a surge capacity for mobile and community COVID testing, and the second one is a surge capacity for project management support to support that community testing. So for this first one with testing, I'm on slide 2 here. The scope is for future COVID-19 emergency surge testing services. What we're looking to do is recognizing that there are routine testing capacities that already exist. We do not have dedicated surge response capacity. So in preparation for potential future surges, we're looking to establish a roster of pre-qualified vendors who could be able to do just that. These contracts will have firm commitments regarding how many testing units and locations a vendor can scale up and on what timeline. For a surge scenario, that timeline is particularly important. This will help avoid the need for emergency procurement and contracting in the future by having the surge capacity available. So under our current contracts, pricing is based on a per test or per team per day basis. We encourage bidders to put forward similar structures, but since this was sort of a new scenario, we didn't know exactly what type of pricing structures would come back in, so we left it flexible should they want to get creative. The ancillary costs, vendors would be managed by existing testing team and staff under Test and Trace or Office of Ambulatory Care, and as I said, it would be supplemented by additional project management support under the RFP we'll talk about in a moment. No additional internal resources are expected beyond those. So we're looking for a 5-year minimum criteria that the company would have 5 years in business and public health testing, experience with rapidly deploying health services. Again, the speed is important here in a surge scenario. Substantive criteria, you see broken down 30% each for relevant experience and thoroughness of the plan, 25% for cost, and 15% MWBE. And you see the evaluation committee there made up of a variety of people from different departments with relevant experience in this space. So in late March, we published the RFP. We held a pre-proposal conference, and then 15 proposals were received by mid to late April. At the end of April, we debriefed on the vendor proposals, and in early May, the evaluation committee finalized scoring. We're putting forward the 6 highest rated firms as those selected. So with these past vendors, 4 of them we have past work with, 2 of them we do not in quite the same way. So DocGo, consistent satisfactory performance, MWBE performance, dipped in winter 2021, but has made good faith progress to restabilize their attainment. MedRite has been consistent satisfactory performance. Premier, likewise. For Fulgent, they have also had consistent satisfactory performance, but early 2021, they also had some challenges, but have made good progress to get back on track. CTS and Elevation, we don't have direct experience with in quite the same way. We've done some informal coordination with CTS, and they've been a strong operational partner. And Elevation, we currently have a current community testing vendor contract with them, but we've not used them directly. They have, however, been a subcontractor for CIC Health, who does school testing primarily in charter schools and some of the non-public schools where we do testing. And they've been a strong subcontractor for CIC Health in that scenario.
CTS is not one of the vendors, it's Centera.
CTS also Centera, that's right. So we'll make these updates. Thank you, committee chair, for flagging that. We'll make sure to update those before they go to the full board. Next slide. So MWBE utilization, we see that 8 MWBEs were invited and 2 responded. 20 non-MWBEs were invited and 13 responded. On the bottom, on the bottom, we can see the utilization plan summary from each of the 6 vendors that we're putting forward here. Each of them have at least a 30% target with a 100% goal with Elevation Health as their New York City certified WBE. You can see the subcontractors listed there as well. So what we're seeking is approval to award contracts to these 6 firms with a $0 contract value to provide COVID testing vendors for an emergency response. So this is 0 contract value because we will require written emergency authorization from Dr. Katz to activate these agreements, and then OMB will be informed of that approval and asked to provide agreement to cover those costs. In essence, no costs will be incurred without prior approval from both Dr. Katz and OMB. Should we need to activate, you see here on the 3rd bullet what an estimated cost might look like. In a Delta surge scenario, it could be about $75 million. That means, and that's based on a relatively smaller number of teams for a longer period of time, as opposed to an Omicron surge scenario, which might be a greater number of teams over a shorter period of time. And that would be closer to 26 million. Again, no costs would be incurred if they're not activated. All expenses are covered by the T2 MOU between OMB and Health and Hospitals, which is to be extended beyond current expiration date. And we anticipate an August 2022 contract start date. So thank you for the opportunity to put this before you, and I'm happy to answer any questions.
All right, any questions?
Yes, it's Barbara Lowe. Good morning.
Good morning, Barbara.
Yeah, I'm having growing concerns just globally about our changing infection rate every day in the city and what's occurring right this moment. For the future, when we're scaled up, will we have enough capacity at each site to do the education about what's occurring and how to stay safe? because I'm believing that there are so many mixed messages. Now, one of the important things is that people know how to stay safe, because I think there's a lot of confusion right now. So the educational component will be, or the public education component will be very important.
Yeah, that is absolutely a significant ongoing need, right? We see that with the media campaigns that the city and we all have been putting out in terms of trying to educate people around best practices. We've had the outreach team that's been out there for quite a long time that had been doing outreach and engagement and education with community members around best practices of that sort. And then we have these new types of models that you may have seen launching over the last couple of weeks here, the test to treat model that brings treatment right to the point of care, right to the point of testing. So we can get someone right when they test positive right through. But those preventive measures, right, those best practices, masking up indoors, all of those, absolutely. That is absolutely critical. And that is part of the conversations that happen at these units in terms of talking with patients, making sure that everyone certainly on site is practicing, good hygiene in terms of the staff and the patients with masking, hand sanitizing, and so forth. So I do think that there is adequate capacity. This is a practice at the mobile testing sites that we've had for maybe 2 years now. And so I do think that we've gotten pretty effective at educating patients when they do come on site, along with that additional community education efforts that I mentioned.
Well, kudos to you all. You've done a magnificent job. Thank you.
Thank you.
Thanks, Barbara.
I have a question and a
Sally, go ahead.
comment. Yes, a question and a comment. One, thank you for providing the board of directors notice after Mitch does the emergency authorization, because it is important to at least know if there are going to be any differences, not just in cost, but in practices. So that is welcome. The other thing is, would you or maybe Khaleesi know whether we've ever done this sort of standby authorization like this before?
Thank you for flagging on the board of directors piece there. Apologies that I skipped past that line too quickly. You're right. The board of directors will be notified and provided the expected expenditures at that time. My understanding from the procurement team is that we modeled this after some of the requirements contracts that are relatively standard practice in other areas of the operation, facilities management or IT, where you have vendors that are sort of on standby for that capacity. But Khaleesi, please do chime in and correct.
Hi, Sally.
Yeah.
Yes.
I think you're right, Chris. Yeah. I'm sorry, Khaleesi, go ahead.
We have done this sort of pool procurement contracting. You could remember we did it with our emergency services contract, where in case of an emergency or natural disaster, we have a pool of contracts in place to respond accordingly.
Okay,
That was
thank
the
you.
most recent one.
All right. That's it.
Thanks, Sally.
Yeah, thank you.
Thanks, Sally. Any other comments or questions? If not, could I bring to a vote then? Dr. Martone?
Yes.
Thank you. Barbara Lowe?
Yes.
Sally Hernandez-Pinheiro?
Yes.
And Jose Pagan?
Yes.
Thank you. Motion carries. Ted, if you can go on to the next one.
Good morning. So the next resolution is authorizing New York City Health and Hospitals Corporation to enter into standby contracts with the following 4 firms: QED Inc., doing business as QED National; Rapid Reliable Testing Inc., DBK.go; Somos Healthcare Providers Inc., and Huron Consulting Group Inc., to provide COVID surge project management services when necessary, as directed by the system's president, with each contract to have a 2-year term, and with the set of contracts not having a pre-established not to exceed amount. So again, this is very analogous to the proposal that we just discussed around testing. This is a surge capacity for project management to support that testing that would happen out in the field. So we do not have, So we currently have significant capacity within Office of Ambulatory Care and Test and Trace to be able to support the day-to-day operations. What we're looking for is to be able to, if we need to go from today's 150 or so testing locations to 300 testing locations or 350 testing locations, we want to be able to have standby project management support that can help with facilitating street permits, can help with identifying which specific locations in the city we should go to, can work with community partners to correctly publicize that those units will be available in those communities. So those types of project management activities is really what this proposal is about. So we're seeking to establish a roster of pre-qualified vendors to provide project management support with operational expectations, cost structures, and reporting obligations, just as there was on the testing side. We aim to establish firm commitments regarding staffing availability and ramp-up timeline. Like testing, the timeliness here is critical. Test and Trace previously worked with one of these vendors, QED, for project management support regarding the daily operations of surge vendors engaged during the Omicron surge, and that performance was very strong. So while general vendor project management support exists, dedicated surge support doesn't. We encourage vendors to supply pre-negotiated hourly or weekly rates, but again, we left it flexible because we didn't know precisely how they might want to put forward. The vendor would be managed by existing staff at Test and Trace or Office of Ambulatory Care, and no additional internal resources expected. RFP criteria, we were looking for firms that had 5 years in business and experience deploying project management support in an emergency response scenario. We had 30%, if you could go back for a moment. We had 30% for both relevant experience and thoroughness of the plan, 25% for cost, and 15% for MWBE, and the evaluation committee was the same as with the testing RFP we discussed a moment ago. So the overview of procurement was also sort of mirrors the testing RFP, with us publishing in late March, and by early May, the evaluation committee finalizing the scoring, putting forward the 4 highest rated firms as the selection. So past vendor performance. So 2 of them we've had project management experience recently. QED was consistent, satisfactory performance. That contract was held by New York City DOHMH. With Huron, consistent, satisfactory performance and MWB attainment, that contract was held by Health and Hospitals Test and Trace. They specifically helped us on the testing space, setting up some of the brick and mortar testing sites that we opened about 2 years ago. Then 2 vendors we have experience with, but not in the project management space. Somos, prior testing experience, and DocGo, rapid reliable testing, also prior testing experience, but not project management experience with us. So for MWBEs, we invited 2 and both responded. We invited 5 non-MWBEs and 4 responded. We're proposing, as I said, to go forward with QED, DocGo, Somos, and Huron. You see each of them have at least a 30% attainment goal put forward, including an 85% from Somos and 100% from QED, which is a New York City and New York State certified WBE. Next slide. So we are seeking approval to award contracts to 4 firms with a $0 contract value to provide contingency emergency project management services. Like with the testing proposal, we would get written emergency authorization from the President and CEO to activate the agreement. Then OMB will be informed and asked to provide agreement to cover the costs. In addition, following that President and CEO activation, the Board of Directors will be notified and provided expected expenditures. We estimate that it could cost between $2 and $5 million a year, and no costs will be incurred if they're not activated. This is all covered under the T2 MOU between OMB and New York City Health and Hospitals, and we are seeking to have these contracts have an effective date starting in August of 2022, so about a month from now. Thank you.
Thanks, Ted. Again, any questions or comments?
Just
Yes.
a quick,
Hi, is that Sally? Go ahead.
just a quick question. Do we usually in the point system in evaluating the contract, do we usually do 10% MWBE or is it 15?
These ones were 15. I can't speak to the normal practice. I don't know if others can, but these ones we did 15%.
Police, is it usually 10% or am I misremembering? Alicia?
Oh, maybe the
Okay,
mics weren't on there.
Sorry, the mic went off. I'm sorry. Yes, Sally, usually we use 10%, but it can be adjusted depending on the services we require.
Okay, thank you.
Barbara, I think you had a question?
I believe that, we have all these changing events occurring. Will these particular sites have oversight for the delivery of services in their communities or the targeted communities? Is that what we're doing?
These sites are intended specifically to be able to provide COVID testing. Primarily,
Yes.
that will over time likely take the form of rapid testing with some PCR. But the service to be delivered under the prior contract we discussed is testing. And then these are the back end support professionals that will help to coordinate, make sure everything is buttoned up. So when those testing staff get to a location, the community is aware they're coming. It's been well publicized. All the permits are in order. They'll help to make sure we're reconciling the invoices correctly, all those types of things. This is sort of the back end support to make sure those services in the field go smoothly.
You're definitely the experts in the field. Thank you.
Excellent. Any other questions or comments?
Yes, it's Pat. I have a question.
Go ahead, Pat.
So just for clarity, thank you. The procurement of the tests themselves, the actual vendor's not doing any of that.
Under this contract with the back end support, no, they're not. Under the prior contract we discussed a few minutes ago, they are responsible for all of the procurement of all of their needed supplies. So that, yes, that includes tests. That would also include folding tables, wipes. It would include everything end to end. They need to be sort of an all-in-one package. They can drive a unit up to a street corner. They can show up at a community event, and they have all of the supplies they need. All we're there to do is manage them, make sure they're sort of maintaining a good amount of quality, that they're maintaining a quality experience for the patients, that they're getting test results to the patients in a timely manner. So we're on that side of things, but they are responsible end to end to provide all supplies.
So I can appreciate them WVE weighing higher here because I think they're at a disadvantage in the other one if they do not have the funds to procure enough of the supplies if and when they need to do that first and then get reimbursed, or have to pay it off afterwards. I think that's a part of the MWB challenge, and it sounds a little different and probably easier in this process for MWBEs to participate. So thank you.
Thank you for that. Also, Ted, just quickly with respect to the vendors that we didn't have experience with before, this Homos and DOTCO, do we have references going back just to?
We do, as well as
some sense of it.
We do, as well as our own experience with them on the testing side, right? Because there is sort of this handoff that happens where the testing work itself isn't without project management duties, right? The vendors that are performing those testing activities, they need to make sure that the vans are fully stocked with those tests and those supplies. They need to make sure the right staff are getting there on time and doing an adequate job. So they need to do daily reports to us on what the volumes are looking like. So those testing vendors do already have, in this space at least, well-tuned skills relevant for project management work. But yes, we do also have recommendations as well, or references, I should say.
Okay, thank you for that. All right, let me go to I'm sorry, was there another comment?
Yeah, just one more for Ted.
Sure.
Ted, how much do we have in terms of resources to make referrals for mental health issues?
For these locations, there's not a direct connection in that way. We've come before the board before to discuss the Street Health Outreach and Wellness Program, which is a mobile venue. We have 8 units out on the street today. They do provide both COVID testing as well as those types of referrals and even certain on-site services. These units, however, specifically in the surge environment, are intended to be sort of specialist, just doing COVID testing, trying to move through as many tests as they can, as quickly as they can, and efficiently as they can, in order to provide the capacity needed during that the city needs in a surge moment. And I also just want to, I should have introduced myself at the beginning. My name's Chris Keeley. I'm Chief Operating Officer for the Test and Trace Corps and also the Office of Ambulatory Care.
Thank you.
All right, any additional questions, comments? If not, let me go to the vote. Dr. Martone,
Yes.
Barbara Lowe,
Yes.
Sally Hernandez Pinheiro,
Great job, Chris. I vote yes.
Thank you.
and Jose Pagan.
Yes.
Motion carries. If we could have the last presentation. Excuse me.
Hi, good morning, everyone. My name is Nicola Davis. I'm the Chief Pop Health Officer, and I'm joined here by Emily Foote, who is our Senior Director for the Social Determinants team. And we'll be presenting on the resolution authorizing New York City Health and Hospitals Corporation, the system, to enter into a best interest renewal of its contract with New York Legal Assistance Group, Nilag, under which Nilag provides certain free legal services to the system's patients for 1 year for an additional amount not to exceed $1,889,182, which, when added to the previously approved funding of $4,160,424, brings the total not to exceed amount to $6,049,606. Emily?
Thanks, Nicola. Good morning. My name is Emily Foote. I'm a social worker and senior director on Dr. Davis's team. As you may be aware, Health and Hospitals operates one of the country's oldest and largest medical legal partnerships with the Legal Health Division of Nilag. Nilag is a nonprofit civil legal services organization, and medical legal partnerships, or MLPs as they are known, are one of the most innovative and powerful interventions for addressing social determinants of health. In this model, attorneys function essentially as extensions of the medical care team and are able to assess and address patients' legal needs through the lens of medical, behavioral, and social determinants of health. Health and Hospitals has had agreements in place with Nilag since 2002, so nearly 20 years. Initially, they were funded externally for their work, and we simply provided space in our hospitals. However, over time, we began funding them directly. And in 2019, the Office of Population Health was able to establish a single centralized agreement for services. That agreement expires in August of this year, and we're here this morning to request a best interest renewal for 1 year, allowing us time to launch an innovative new referral and appointment scheduling system in our EMR, Epic, which will give us more operational control of this work, plus the ability to better measure the impacts and the financial sustainability of the program. Next slide, please. So there are 2 principal components of the medical legal partnership between H&H and Nilag. The first, of course, is providing direct legal assistance to our patients in the context of their overall health care. The second is to provide education and support to Health and Hospitals frontline staff who are managing complex social needs for patients. This education, as well as the ongoing relationships built over time between attorneys and members of the care team, like doctors and social workers, invariably generate more and better quality referrals. We've listed here on the slide some of the many health-related legal services that legal health attorneys provide, including those related to housing, immigration, benefits, and income support, and advanced care planning. The value of providing these services as a part of healthcare really cannot be overstated, and I'd just like to share a story of a patient we were recently able to help through the medical legal partnership. In July of 2020, a staff member at Queen's Hospital referred a patient who had been admitted for 3 months for COVID-19. COVID had damaged her lungs so badly she was on oxygen and was in need of a transplant. However, unfortunately, she lacked immigration status and had only emergency Medicaid, which did not cover the transplant. With extensive work piecing together the patient's immigration history and gathering the necessary documents, the legal health attorney was able to file a medical deferred action, and the patient also attained full Medicaid coverage in the fall of 2020. Subsequently, she was transferred to NYU Langone, where she received a successful transplant and was then discharged home in January of 2021. Legal Health is continuing to assist on the still pending medical deferred action in the hope of securing longer-term immigration relief. And it almost goes without saying that the outcome here would have been very different without Legal Health. So in addition to compelling individual stories like these, we are really very interested in collecting and analyzing more comprehensive data to make sure we're maximizing the availability of this resource for our patients, and in order to demonstrate the social and financial return on health and hospitals investment. Next slide, please. Due to the decentralized nature of Nilag's work at health and hospitals over the years, we have lacked the degree of operational control that's really needed to optimize this work. This was a main motivator for us in centralizing the service agreement back in 2019. Unfortunately, plans for a first of its kind referral and scheduling system to be built in Epic were delayed due to the pandemic. However, we were able to get the build started late last year, and it is now nearing completion. In April, Health and Hospitals Clinical Services Planning Committee approved us for continued funding, including for 2 new staff lines to support the new scheduling system. We're actively recruiting now, and we are expecting to go live with the new system by the end of September. I also want to note that while the pandemic interrupted operations, Nilag and population health leadership teams were able to quickly transition to a remote services model, thus successfully maintaining the availability of these services to patients at a really consistent level. We have seen that virtual legal services have provided benefits to many patients, both in terms of flexibility and convenience, but recognize that they may not meet the needs of all patients. And we are now working to implement a hybrid model where patients have the option of an in-person or a virtual telephone appointment. Next slide, please. This is just a quick slide I'll go through fast. I wanted to show a snapshot of services provided to patients through the MLP. As you can see on the middle row, Nilag serves close to 4,000 patients a year, a number we're actually looking to increase with our new Epic referral and scheduling system. Next slide, please. We are extremely confident about the future of this program and the benefits to our patients, and we plan to work over the next 12 months to secure some critical information, including the operational implications of running the legal health program using the Epic system, as well as insights from early Epic data on appointment utilization. The new system will expand access for more patients, help us in population health, better demonstrate the social and health impacts of the intervention on patient and population health, and let us build a robust ROI, a return on investment for the program. I'll summarize our formal request in a few moments, but in short, the proposed renewal would last from September 1st, 2022 until August 31st, 2023, and have a total not to exceed cost of $1,889,182. We've included a detailed budget in the appendix, but the bulk of these costs go to pay Nilag program personnel, including a cost of living adjustment and fringe adjustment. Next slide, please. In preparation for submitting this request, we have done some vendor and pricing due diligence. While there are several nonprofit legal service providers in New York City, none have Nilag's unique expertise in health-related legal needs and medical legal partnerships. It's also worth noting that in 2019, the Mayor's Office for Immigrant Affairs released a request for proposals for public hospital-based immigration legal services, and they awarded the contract to Nilag after a thorough review process. The City Council has also funded Nilag for additional services at health and hospitals for the last decade, actually renewing its commitment just last month. In terms of pricing, we pay Nilag a rate of approximately $2,600 per clinic day, and there are over 700 such clinics provided annually at health and hospitals. Nilag staff's salary steps are comparable with the other large nonprofit legal service providers in New York City. We are happy with Nilag's ongoing commitment to our staff and patients and their willingness to flex their services as needed. Next slide, please. This is just a screenshot of the official vendor performance evaluation, and as you can see, Nilag has met the performance and overall quality rating threshold. Next slide, please. This slide reflects our assessment of Nilag's workforce diversity. While they do meet the official standards of employing women and minorities, and their EEO status has been approved, we believe there's some opportunity for improvement here, particularly at the board and management level, and we have initiated recent conversations with Nilag's leadership team about this. Next slide, please. So in closing, we are requesting approval of the resolution for a 12-month best interest renewal of our agreement with Nilag. The renewal will maintain the terms of the existing agreement and provide for a Nilag program personnel cost of living and fringe adjustment. The NTE will increase by $1,889,182, and the new agreement will expire in August of 2023. This additional 12 months will allow us time to launch our new Epic referral system and evaluate procurement of a future multi-year agreement to begin in September 2023. This concludes our presentation. Thank you very much for your time and consideration. Happy to take any questions.
Thank you so much. One quick question. Do we have a breakdown when we look at the actual clientele of who are English as first language and who are not, and particularly Spanish as first language? I'm just curious, do we know offhand what those percentages are?
Great question. I don't have the percentages in front of me. The data that is reported back to us by Nilag is in aggregate, and we don't have great control over their data collection, the demographic data collection. So I can say what they do share, there is a preponderance of Spanish-speaking patients. There are, because of our investment in the immigration legal services in particular, many immigrants, many English as second language speakers. And I'll also just say that the EPIC system is going to give us much better data on this.
I think that'd be helpful. The reason I ask in part because I suspected that would be the case. You know, if you look at the breakdown, the staffing, you know, if you look at the support staff, 51%, I think, was a number that were Hispanic. So, you know, you have that piece, but the professionals, 5% were. And given that English is my first language, and I have enough trouble understanding legalese as it is, I'm just wondering if that would be another factor that could be brought to them as far as recruitment of professionals that are also Spanish speaking. So just a thought, but it just kind of struck me when I look at the numbers.
Thank you. Yes, we agree, and we are, as I mentioned, we've recently opened conversations with Nilag's leadership team about this.
Okay. Other questions and comments, please?
Go ahead, Jose.
Yeah, just a quick question on like, is this exclusive, meaning that if we require specialized services at some point, or we could go with other vendor, any other legal assistance groups that provide this type of work?
So I'm not an attorney. However, my understanding is this is a non-exclusive agreement, and we are free to work with other legal services providers as needed.
Thanks.
I just wanted to say I know Nilag, they're a terrific group. As a former legal services attorney, I did a lot of this work, and it's incredibly helpful work for the client base that is being served. I did have some concerns about kind of the depth of detail of operations, and I'm glad that the EPIC system is going to fill that area. I wonder if they have even gross numbers about, well, as you said, it's difficult to access demographic information from them, but whatever they have would be useful, because I'm not quite sure how you evaluate success, because success can be like helping the woman with the transplant, even though she may or may not end up getting deported. So I'm glad that we have the EPIC system, that we'll be working with it. That's it.
Thank you. And happy to report back the demographic data that we do receive, if that would be helpful.
Yeah, thank you.
Just out of curiosity, again, this is such a cutting edge, very important piece that I think a lot of healthcare systems don't necessarily consider part of their responsibility. And I think bravo to us that we do consider that. But I'm just wondering, because you mentioned there's no other of these agencies that tend to have the same level of experience with healthcare systems. Does Nilag work with any other healthcare system? Or do we know of any other systems that are providing even remotely, these type of services?
Great question. And yes, Nilag's legal health division does have medical legal partnerships with, I would say, most of the other big New York City systems, including Mount Sinai, Columbia, NYP, I believe Montefiore. And then just a quick note, there's another small firm I'm aware of, very small, called Terra Firma. They specialize in pediatric medical legal partnerships. So in particular, they're looking at the rights and needs of unaccompanied minors.
All right, any other questions, comments? All right, if not, we can go to a vote. Dr. Martone?
Yes.
Barbara Lowe?
Yes.
Sally Hernandez-Pinheiro?
Yes.
Jose Pagan? Motion carries. Thank you so much for the presentation. All right, if we can, then let's move on to our reports. If we could start with Dr. Allen and the Chief Medical Officer report.
Thank you, Dr. Calamia. Can you hear me?
I can. Perfect.
I have the pleasure of reporting in from Harlem Hospital today. Sorry I can't be with you. What I'd like to do going forward, in medical and professional affairs, we have clinical councils and clinical service lines, and a lot of amazing work is happening in our clinical service line. If you go to the next slide, please. Aligning with the strategic goals and initiatives of the system, I would like for the ambulatory care service line to report in under the strategic pillar of access to care. I'm wondering if Andrew Wallach is with us.
You've got Hannah Jackson.
Oh, Dr. Jackson. Can we go to the next slide, and Dr. Jackson can take it from here.
Perfect. So thanks, everyone. So today I'm going to talk a lot about the indicators that we think about when we think about access to care for our patients in the outpatient services. So I'm going to quickly bring us through a few. One that we really care about here is primary care continuity rates. And that's the idea that when you come to see your doctor, whether it's for a scheduled visit or an urgent visit, that you're seeing the doctor who knows you best, your primary care doctor. And that's reflected in our primary care continuity rates. I'm also going to talk about no-show rates. A lot of times we think about no-show when we think about clinic efficiency and dollars, but actually no-show really impacts access. If your patient doesn't show, that was an appointment that someone else could have had, but it's also an appointment that has to get rescheduled, and that again affects access for everybody. Next, I'm going to tell you a little bit about video visit rates. So that's a way that we've really improved access. Obviously, had to turn it on very quickly when COVID started. And had the majority of those virtual visits as telephonic only. We've really made a lot of efforts in the last year and months to improve the number of those visits that happen by video. We know that's a way that's going to improve access for our patients in the long term, and we think that video access gives them sort of better care and a better experience. The last two are related to COVID-19. One is around vaccination rates for our patients, and the last one is about therapies for our patients who test positive, and assurance that it's, again, equitable access and that we're treating our patients that we know best. So the first one for continuity rates, Two of the things that we've worked a lot to improve our continuity, which just years ago was down at 60 or below percent, meaning that it was almost a 50-50 chance that a patient was seeing their own doctor when they came in, is that we've done a lot of work with our templates. Rolling templates means that schedule times open up, whether it's 1 day, 2 weeks, a month, or 3 months in advance, which means that there's always appointments available for a patient, whether it's urgent or they need to be rescheduled to see their own doctor. We've also worked a lot with the contact center over the last few years on scripts to really emphasize continuity and ensure that we're not just scheduling patients to the next available, but to the next available with their own provider. Next slide. So no-show rates, as I mentioned, the templates actually also help with no-show rates. If you schedule a patient for their annual visit today, the chance that they know that they are free with childcare and no work restrictions is likely impossible. And so we've, again, really worked to schedule appointments much closer to the appointment time. And right now we're circling around 21% overall with even better no-show rates within our specific primary care clinics. This is for all outpatient. We've also been expanding our text reminders. So we are live right now for all primary care that everyone gets a text reminder 2 days before their appointment where they can confirm their appointment. And we have just started the work of expanding that to specialty clinics as well, where no-show rates are often higher. Next slide. So video visits, you can see, basically tell when COVID is surging based on when this graph surges as far as the number of visits that we do virtually. You can see the first wave back in April of 2020 when we immediately sort of started doing a lot of our visits virtually. We still do a large number of visits virtually, weekly about 10,000. But you can see that bottom level, the light blue video visits are becoming a larger and larger percentage of the visits that we're doing. And that comes from a lot of work we're doing with provider education, patient education. We have 2 navigators that we got through a grant who are working and reaching out to our patients who have difficulty with video visit access and really working to drill down on how we can improve the video visit experience. And then for vaccination rates, 72% of our primary care patients have had at least 1 dose of the vaccine. You can see this is a breakdown of all of our sites. Lincoln is doing a tremendous job with 78.7% of their patients. But overall, all of our sites are generally in the 60s and 70% as far as this goes. And we continue to make this a priority when we're seeing our patients in clinic. And the last slide.
All right, when you say have received 1 dose, do you mean the first COVID, like the very first vaccine?
So 1 dose can mean a single dose of like J&J, which is a complete, or it can mean 1 dose of Moderna or Pfizer. So across the board, have received at least 1 dose.
Yeah. Okay. At some point, I mean, we may have the information, we may not. It would be helpful to know what percentage have received other than J&J, or categorize J&J separately.
Yeah.
See both doses.
Yeah, absolutely, and we can absolutely share that. I'll mention that as you all know, the definition of completed has changed, right? So now it's having a booster is really completed, and for some having 2 boosters. But absolutely, we can share that breakdown with the board.
Yeah.
And do these numbers include pediatrics, you said, or not?
These numbers, and this is adult primary care.
Okay.
And the finals, okay, perfect. And so we are also keeping a close eye on the demographics of patients who are receiving Paxlovid. As you know, we're a primary place where New Yorkers get COVID treatment, whether or not they are actually normally our patients. And so we want to make sure while we're providing the service to the city that we are also providing it to patients who rely on us most heavily. In June, we did 3,500 Paxlovid prescriptions, as well as 474 monoclonal antibody infusions. And at the bottom, you can see the demographics of the patients who've received those. I will note the English speaking, and you'll find this probably across the board, is that data is only as good as our EPIC data for patients' preferred language. And I'll say in particular, that's often a place as well as sort of race, where race unknown just when you're registering a patient who doesn't normally get their services through us, sometimes can be skipped over or done quickly. And so I'll just note that probably is an overestimate.
Just a quick question regarding those people who are not in our system that are getting, say, the Paxlovid. What detail of information do we get? I mean, is it just demographic? Do we get demographic plus some of their healthcare information? I'm just wondering, how do we keep track, so to speak, of that medically? Go ahead. I'm sorry.
Yeah. So they get registered into our system, which means that we get their health insurance information if they have it, as well as their demographic data, as you would sort of register for a new patient appointment in any healthcare system. If they are part of a system that is connected through us through CareLink, like that another Epic system, you can sort of share notes across the board, but there's not sort of, it's really the demographic data and health insurance data that we would then have on the group overall.
I think it's just, the issue, for example, of medications that are impacted by the Paxlovid. I just wanted to know what level of detail we get to make sure that we're not having drug interactions and so on.
That's a great question. Yeah, so it's one of the more complicated conversations that I have personally with patients. So we do, if they are an Epic system, we can often see their medications and verify. You also have the option of calling the pharmacy to verify. But a lot of these prescriptions we actually end up doing through virtual express care, where there are providers who are doing this all day and have gotten very good at the conversations with patients to really ensure they understand what drugs not only are you prescribed, but are you actually taking. Because yes, you can spend hours on the website sort of figuring out sort of interactions. And that's, absolutely critical to sort of doing this safely.
And for people that don't have, primary care, it's probably a good place to do an entrance to our system.
Exactly.
So might be interesting to see that.
Exactly.
Okay. Sorry.
It seems that the percentage of white patients is disproportionate relative to the percentage in the total population. We had a chart that showed, I don't know, white patients were like 6%, but in this instance, they're twice or slightly more than Hispanic, Latino X. It's a curious observation. That's all. Maybe it just may be the patient mix, whatever. Just an observation.
Yeah, no, I appreciate that. And I think, throughout COVID, we've always, especially because Health and Hospitals was a testing and then a treatment center for the city, we wanted, again, to be sure that we were taking care of all patients and not sort of the New Yorkers who were best able to advocate for themselves or reach out and get these services. One of the nice things that we've done for patients who are in our system is we have a great flag system. So right now, today, as a primary care doctor, if my patient tests positive for COVID, I'm immediately alerted and actually given step-by-step way to get them to their treatment. And so I think that's really helped us reach our own patients in particular. But absolutely, it's a worthy note.
Thank you.
Yes, Sally, this is Michelle. Thank you for that question. And I think we do need to follow up the percentage of patients by racial and ethnic group who are actually utilizing the medications that we have to offer compared to the demographics for our entire ambulatory population. So I think that's an excellent question, and I would like to follow up with that. Dr. Jackson, we can work with Dr. Wallach.
Yep.
And see how we're doing.
Right. Okay, thank you.
All right, I apologize. I'm not leaving a lot of time here, so I apologize. But if nursing can give their report, thank you.
Dr. Calamia, before we CMO report, I do want to note to the board that there was an article in the New York Times yesterday written by Maureen Dowd following the mayor around and referred to a trip that the mayor took to Jacobi Hospital to the SIM Center, following up on maternal mortality and the work that we're doing within H&H to address maternal mortality and morbidity and the disparities. Unfortunately, the Ms. Dowd reported that the Sim Center was part of Albert Einstein's medical center. So I reached out to City Hall, to their public relations communications, to ask the New York Times to correct that formally, because the Sim Center is an H&H center and not an Einstein. It's not part of Einstein. I thought that was important to share with the board.
Yeah, it's very important. I appreciate that. And unfortunately, here on page 72 of the Times in a little area on the bottom for corrections. But you know what? It would be worthy of them to put another article based on the work you've been doing and the work that we've been doing in this critically important area. So, all right, thank you. I'm sorry now, off to Chief Nursing Report, Dr. Sineas.
We'll keep it brief. I know we're short for time. Just to highlight nursing during the last few months, we continue our partnership with CUNY. We had a successful health equity program titled Promoting Your Health During and Beyond the Pandemic on May 6th, where we had over 50 people register and over 50 people attend. Next slide. We also held the Nurse Antigone Project for nurses that presents the dramatic reading of Sophocles and the nurse Antigone. And it was a great presentation in a play where we had our nurses, Antigone, excuse me, our nurses were on, not necessarily on set, but they were part of the play where we had over 700 registrants as well. It was well attended, and we were able to debrief about what our nurses face and the challenges they continue to face beyond the pandemic. Thank you. Next slide. We continue to have our robust nurse leader work groups, where we have 7 nurse leader work groups right now, really establishing the infrastructure for nursing leadership, starting from the orientation to the competencies to our visibility within New York City at different conferences. Next slide. We continue to enroll individuals and employees within the Behavioral Health Associate Academy. We're very proud that the last cohort had 87 graduates in total, where we're working with behavioral health. We also released the CWA protocol in EPIC, and we also hired a new Senior Director of Nursing Education, Nicole Morris, who's going to really be implementing a lot of the necessary technology for nursing education. Next slide. We also, in partnership with the Office of Quality and Patient Safety and MNPA, rolled out the Director of Nursing Quality Training, where we have now directors of nursing quality at all of our acute sites, and they will really be leading the infrastructure for the new care delivery model to ensure that our nurses are implementing best practice within nursing quality, focusing on the nurse-sensitive indicators to improve our metrics around CAUTI, CLABSI, falls, and pressure injuries. Next slide, please. We also are now partnering with CUNY for nursing research. I'm very proud to say that we have kicked off a new grant with the NIH, where we have many doctoral projects and also nursing research, particularly at Bellevue and Elmhurst, as we roll out nursing research across the system. And that is very important for nursing excellence. Next slide. The Clinical Ladder continues to be a successful program in partnership with NYSDA. We have over 1,000 nurses who have applied to the Clinical Ladder. We'll be working very closely with NYSDA this month to ensure that all of our nurses complete their projects. And again, these projects are professional portfolios to enhance nursing quality across the system. And we also have celebrated National Nurses Day this past quarter, and that was actually in March, but we continue to focus on certification, particularly for our nurse leaders, because that is important for nursing excellence. Next slide. Social work, we're doing a lot within the social work domain. We most recently launched the Social Work Shared Governance Council, where the frontline social workers will really be leading the way to innovate their practice with Senior Director Eva Sanders at the Office of Patient-Centered Care. Thank you. You can move on from social work. Next slide. Perfect. So we are also continuing our work around professional shared governance. Our next report out will be August 2022 this year, and we're really focusing on dashboards now, so all of our frontline nurses will have their metrics around quality to really start driving performance around the work that they do every day for our patients. Next slide. Nurse residency program continues to be a successful program where we have over 1,000 nurse residents in this program. We continue to see an increase post-pandemic within our retention rates of all of our new nurses who are part of this program. It's really an important program. We're seeing a lot of new nurses want to join health and hospitals because of this program. We're also expanding our RN mentorship program with more retirees. Recently, we had more retirees join this program, but we're also creating a 3-tiered approach to nursing mentorship. The publication was just released, and we're doing a lot of work around mentorship of graduates of the nurse residency program as well to come back and mentor our new nurses. So within our retirees and our nurses mentoring one another, with our chief learning officers program of mentorship across the system, we're doing a great job around mentorship. Next slide. And last but not least, I just want to announce that we successfully submitted the New York State Staffing Committee, which was a huge endeavor in partnership with our legal department, finance, and all of our labor partners, where we submitted our New York State staffing plans as of July 1st, 2022. We just received notice today that we will have to enter information into HERDS as well. But ultimately, it was great collaboration with our labor partners, as always. Thank you so much. That concludes my report.
Thank you. Bravo, just extraordinary work. Kudos to you and department. Any quick comments? Because we are running very behind. Apologies.
Just quick comment. At some point, could
Sally.
we talk a little bit more? Could you tell us a little bit more about the work that individual councils are doing thus far? I think they're a terrific, it's a terrific project. And at another meeting, it would be useful to hear a little bit more about what they're doing.
Absolutely, will do. Thank you so much, Sally.
Thank you.
Thank you. All right, if we could move on to Metro Plus Health Plan, Dr. Schwartz.
Yeah, good morning. It's Dr. Shah for Dr. Schwartz. Just a point on the first slide. Next, please. Just to alert the board that as a result of the 2023 budget, there is welcome eligibility expansions across several lines, including Medicaid, Essential Plan, and Child Health Plus. On the next page, please. I think it's important to note, based upon the discussion we've just had, for Medicaid, CHIP, and Essential Plan, starting in March of next year, the guaranteed coverage for postpartum care will extend to 1 year. In addition, for people in the Essential Plan, they will now be eligible to receive community-based long-term services and supports. Next slide, please. Of note to Dr. Jackson's presentation, effective of April of this year, the budget does allow telehealth visits to be paid at the same rate as in-person visits. This is a 2-year pilot, at which point the state will study the impact of this to see if it needs to be continued. This will also include telemental services. Next slide, please. The membership continues to grow and is on target, and actually sort of exceeds the target for this year and is up for 8% in the last 12 months. Of note, in the second bullet, the lifting of the HIP mandate for new city employees starting in January of 2021 has resulted in an average new member enrollment that is 3-fold higher than before into Metro Plus Gold. Next slide, please. Next slide, please. Okay. I do want to focus a little bit on the quality side. Metro Plus continues to do exceedingly well on the quality measures themselves. These are the measures that are based on HEDIS, and the state has adopted them for the quality award, its own quality assurance reporting reward, or QAR. For example, in Medicaid, Metro Plus was equal first in terms of the quality scores. Unfortunately, in terms of consumer satisfaction, we didn't do as well, as a result of which in both the Medicaid and HIV SNP, we fell into the second tier. And we welcome the collaboration with Drs. Wallach, Long, Jackson, and others to really improve on the consumer side, which a lot of it is dependent on access to care, both primary care and specialty care services, and improvement in in access will also result in hopeful improvement in the CAP surveys. Next slide, please. In terms of COVID vaccinations, our current COVID vaccination rate is 70%. That does, Dr. Calamir, include children. And if a large proportion of our membership, at least 35%, is children, so we believe that given that higher percentage of children in our plan, that we will have a slightly lower rate to the overall population of 87% that's seen in New York City to have received at least one dose for all eligible individuals. Next slide, please. Continue. Next slide. Keep going. Yeah. And finally, I just wanted to alert the board about this important new benefit. It is it's called ILS, or in lieu of services. This is medically tailored meals. Currently, it is not a full Medicaid benefit, but New York State elicited and Metro Plus submitted and was approved to provide medically tailored meals to two populations. One population receiving personal care services, where they would get a tailored meal rather than having somebody at home prepare a meal. This will be a medically tailored meal that will be delivered to their house by God's love we deliver. And the other eligible population are individuals with diabetes, HIV, HIV/AIDS, heart failure, and cancer, who, as a result of emergency room utilization or inpatient utilization, will be eligible for MTM services. And the reason this is important is because if this is successful, this could become a full Medicaid benefit. And the goal here really is to reduce ER visits, reduce inpatient stays as a result of providing a tailored meal that's actually tailored by a registered dietitian through God's love we deliver. So not all health plans submitted for this proposal, and not all health plans are approved, but Metro Plus is one of them, providing it for individuals enrolled in Medicaid, the HIV SNP, and HARP. Happy to take any questions.
Great. Just a quick one on that TCA issue. So there might be some reduction then naturally in TCA hours because the delivery of the meals will actually be in lieu of some of those services.
Exactly.
Is that right?
The whole idea is that in the PCA situation, they will get probably an hour taken off their PCA because now the meals are being provided, fully prepared and delivered. So that's obviously a discussion with the member and the plan along with the PCA agency. The other group obviously is not receiving PCA services necessarily, and they're eligible because of their health condition and their utilization of emergency rooms and inpatient admissions.
And of course, the other issue is, the quality of the food, all those things, I guess, have to be taken into account. And just at some point, perhaps you could let us know how you can oversee that and making certain that we're comfortable, that we're getting really good reports back from members and so on. Obviously, given the history of hospital food, so to speak, just want to make certain that there's there's some oversight of that.
So two aspects of this. One is that this is going to be, it's very heavily tracked, Dr. Calamir. The state wants it to be tracked in terms of outcomes as well as satisfaction. So both of those will be tracked. And then if this is, and every 6 months reports will go into the state, it'll be amalgamated to see if that this service was actually cost neutral or actually cost favorable, as well as cost effective in terms of reducing admissions and ER visits for one population, and providing a medically tailored meal for PCS that potentially will be better than the meal that they were actually receiving from the home attendant.
Super. Again, apologies for the delays here, but any other questions at this point?
Your next report, I know that your CAP scores on customer satisfaction are lagging, but if you could talk a bit about the actions you're taking to help address that, I think it would be enlightening.
Sure.
Yeah, I would totally agree. Thank you, Sally. Any other comments, questions? All right, there being none, apologies for running over, but the meeting is now adjourned. Thank you all. Appreciate it.
Thank you. Have a good
Thank
day.
you.
Bye.